So good afternoon, everyone. It's my privilege to moderate today's panel discussion on navigating ethical dilemmas in safety net healthcare, equity, access, and accountability. Before we begin, a few guidelines for our panel discussion. Each panelist has been assigned a specific question in advance to prepare their insights. In addition, there is one overarching question that all the panelists will have an opportunity to address. Following their discussions, we will open the floor to your questions. We encourage you to engage in this important conversation. You have mics down here over on the right, as well as we can pass around a floating mic. Thank you for joining us for this critical discussion on the bioethics of hospital administration. In an era of rising healthcare costs, workforce shortages, and disparities in care, hospital administrators face enormous ethical challenges. Their decisions shape patient outcomes, access to care, and even life and death situations. Consider COVID-19 pandemic. Hospitals around the world were forced to ration ICU beds and ventilators, making difficult decisions about who would receive life-saving treatment. These were not merely medical decisions, but deeply ethical ones. More recently, hospitals have been closing maternity wards in rural areas due to financial pressures, leaving expectant mothers to travel for hours for care, raising serious questions about equity and access. And in some cases, administrators must decide whether to keep underfunded community hospitals open or consolidate services elsewhere, choices that can have life-altering consequences for entire populations. As a nurse, I would like to share that from the perspective of nurses who are on the forefront, in the front lines of patient care, hospital policies directly impact our ability to provide ethical, high-quality care. Nurses often find themselves caught between administrative mandates and patient needs, struggling with understaffing, limited resources, and moral distress when they are unable to give the level of care they know their patients deserve. When the hospitals prioritize financial efficiency over safe nurse-to-patient ratios, the ethical principles of beneficence, acting in the best interest of the patient, can be compromised. How can administrators and clinical staff work together to ensure that ethical considerations are not lost in the pursuit of cost effectiveness? At the heart of these issues are fundamental ethical principles: justice, beneficence, and respect for autonomy. How do we balance financial sustainability with patient-centered care? What obligations do hospitals have to communities, particularly the most vulnerable? And how can ethical hospital administration help build a more just and equitable healthcare system? Today, we are fortunate to have a distinguished panel of experts who will help us unpack these questions. They bring experience from medicine, policy, and hospital leadership, offering insights into the real-world ethical dilemmas faced every day. We hope this discussion sparks thoughtful dialogue and, most importantly, solutions that prioritize both institutional sustainability and patient well-being. Let me begin by introducing our panelists: Dr. Richard Miller, Dr. Mohamed Nakeshbandi, Ms. Stacey Wright, and Dr. Heather Butts. Dr. Nakeshbandi, would you like to start by introducing yourself?
Thank you very much. Thank you, Dr. Roberts. I'm the Chief Medical Officer at SUNY Downstate, Health Science University. I've been at Downstate for almost 13 years. My background is an infectious disease physician. I did my training here at Downstate, so I'm local. It has a special place in my heart. And during my tenure at Downstate, I served in different capacities. I also teach in the College of Medicine, the Public Health School here at Downstate, and also the Public Health School at Columbia. Pleasure to be on this panel with outstanding leaders, and happy to discuss this topic.
Thank you, Dr. Nakeshbandi. Dr. Richard Miller?
Good afternoon. I'm Rich Miller. I'm the Chief Financial Officer for Downstate Health Sciences University. I've been here at Downstate now for 12 years, the last 5 of which have been on the campus side, on the academic side, as the Chief Financial Officer for the university. Previous to that, I was the Chief Financial Officer for the hospital. Most of my career is in hospitals, including 25 years at the University of Chicago Hospital. And in a variety of financial roles, I have to prove myself an administrator, I have an MBA, I have passed the CPA exam, and I have passed the CIA exam for Certified Internal Auditor. But I also have an academic interest in this. Before I became a hospital financial person, I was a PhD in philosophy from the University of Chicago. And there, both I and my wife, who was sitting right over there, had an interest in medical ethics. One of the people on my committee was Alan Dunnigan, which you may recognize as a name in the field, although this is the 80s, so it's a while ago. And Jan's advisor was Stephen Toulmin, who also has published papers in this area. It was an actually interesting time to be in medical ethics. At that point, medical ethics was really taking off and was very research focused at that point. A lot of informed consent around patient issues, but also interested in the more general medical ethics issues.
Thank you, Dr. Miller. Ms. Stacey Wright.
Hi, I'm Stacey Wright. I'm a clinical social worker, and I also have a background in public health. I'm currently a staff therapist for the Downstate graduate and medical school students. Here at Downstate, I've been here about a year and a half now. And prior to that, I've worked in health equity at the New York City Department of Health, and also for a nonprofit that was focused on access to health care. And I'm also a professor and an advisor at Columbia University School of Social Work.
Thank you. And Dr. Heather Butts.
Hi, everybody. So my name is Heather Butts. I am an associate professor at Columbia University at the Mailman School of Public Health. I do not work at SUNY Downstate, but I do have a connection. So I'm actually one of a set of triplets, and my sister is Sydney Butts, who is the interim chair of ENT. So I feel like that sort of gets me into the club, as it were. I'm really honored to be here, and I really want to thank you, Rami, for inviting me. I think this is an exquisitely important topic. I don't know that it gets the kind of attention that it needs, but I really believe that it is in exquisite hands with this really outstanding group of people that are talking about it. So I'm happy to be here. In addition to the work I do at Columbia, I run a nonprofit called Health for Youths that works with underserved young people throughout New York City, as well as Philadelphia and New Jersey. And I also do some work in terms of legal ethical teaching at a couple of other schools here in the city. So happy to be here and looking forward to the discussion.
Thank you, Dr. Butts. So we asked Dr. Miller, what lessons in financial administration can help ensure that patient well-being remains a priority in resource allocation?
So the first thing I kind of noticed in that question was there's a question of ownership there, right? So if you are a not-for-profit organization, then you're all about your mission. And if your mission is patient care, then that's the center of what you're doing. I don't think it's right to think of this as making sure that the patient is at the center of things as opposed to, say, some other group. It is really about, when I think about it anyway, it is really about present patients against future patients, right? Because the sort of ethical value, if you want, of the finance administration part of administration is stewardship, right? It is thinking about having, that you have been entrusted with a set of assets that you want to be there when you leave, right? That you are not just thinking about today, you are thinking about tomorrow. You are not just thinking about today's patients, you are thinking about future patients. I know that you would like, everybody would like to be to have their particular program needs-based, right? To say, right, I need this, this, and this today, and so, right, this is the amount of money I need, right? I have that discussion with the plant department every year, right? They kind of say, your laws are economic laws, my laws are Newton's laws. If this building isn't tuck-pointed, it's going to fall down. And they're right about that. But on the other side of this, as a finance person, you need to think about making choices across different groups, right? In general, you don't have to sort good ideas from bad ideas. You have to sort good ideas from better ideas, right? The ethical piece here is that however you've made your choice, from a finance point of view, the ethical piece is however you've made your choices, at the end of the production cycle, you're ready for the next cycle, right? That you have that what you have been entrusted with is capable of being passed on the next time. That you haven't, left things in a worse state. That's kind of the way I would address that issue of, making sure that the resources you have for your mission are there when you leave, as well as, at least as good as when you got there in the first place.
Thank you. Dr. Nakeshbandi, what are the ethical implications of tying funding or incentives to performance metrics, particularly for underserved populations?
Mary Claire, thank you so much. This is a great question. Tying reimbursement and funding to performance, which we call it pay for performance, especially in underserved patient population, could have really complex and multifaceted implications. On one hand, we know that if we tie payments per performance, we are pushing the organization and the providers to focus on quality measures or performance rather than growing the volume of their practice, which we think that most likely going to improve clinical outcome, it will improve patient satisfaction, it will improve the quality measures. However, if we look at the underserved patient population, those key performance measures, they don't actually reflect accurately the challenges that those patient population face on a regular basis, especially the social determinant of health. As an example, if we have two hospitals, one hospital has 25% of their patient population with lower social determinant of health, and another hospital, they have 5% of their patient population with lower social determinant of health. So let's look at if they're tracking some of the key performance measures, which is readmission, maybe diabetic management, maybe their annual visit or no-show rate. If both hospitals exactly have the same staff, the same clinical care they provide to their patient population, right away, the first hospital will have much lower outcome than the second hospital. Their patient will have a higher readmission rate because they might have transportation issue to go to their primary care doctor after discharge from the hospital. They will have maybe worse diabetic management because they live in a food desert where there is not that many good, healthy options for food. They might not have the same no-show rate because their patients might be afraid of their copayment. So right away, that hospital, if they're not providing appropriate resources to address those social determinants of health, they will have lower outcome. And I want to bring another point. Safety net hospital providing service to underserved patient population, they have a different payer mix than other hospitals. They're mostly serving Medicare and Medicaid patients or non-insured patients compared to private insurance. So to start with, they have a much lower reimbursement. So they don't have enough resources to address social determinant of health. They don't have enough resources to have an army of quality team or performance improvement team or data analytic team that focus on addressing the quality measures. So their quality measures will be lower because they don't have enough resources. Their reimbursement, and they will be penalized more, and they will get into that bad cycle where it will affect their clinical care. And lastly, the last point I want to point out, when we focus so much on the performance measures, we're pushing the providers and the organizations to focus on low-hanging fruits or easy wins. So I will fix this quality measures or this piece, so I'll get penalized less, so I'll get better reimbursement, while we're not looking at a holistic overview how I'm gonna improve the patient care and the patient outcome in my patient population. So I do believe from the ethical standpoint that, pay-fair performance could improve quality of care, but we need to design the performance measures with equity in mind. And if we don't do this, we might run into a problem where we can affect access and clinical care for the underserved patient population.
Thank you. Ms. Wright, what ethical challenges do advocates face when patients' needs conflict with institutional priorities or resource limitations?
So I'm sure there's many statistics on difficulties in maintaining confidentiality, allocating patients to the appropriate resources. But I was inspired by Eric's courageous narrative today to tell you some stories, right, from my own lived experience and from the students that I work with. So one of the things that I think sometimes people don't think about is the amount of moral distress or moral injury that happens to patient advocates and to the patients and the families that they serve. For example, you have a quadriplegic patient who was injured in an accident, and now their managed care will no longer cover their physical therapy or their occupational therapy. So the advocates at the hospital inform their spouse that they need to financially sever their spouse, abandon them financially, or divorce them or separate them so that they can get Medicaid, so that they can continue their care. An elderly patient is told they have to liquidate their assets in order to get proper home care, right? Because they're frail or they're showing failure to thrive, and they cannot function at home, and their family is unable to take care of them 24/7. So again, so that they can get Medicaid. And patient advocates, providers, all inform the patients to do this. And, it compromises people's integrity, right? But it's the system that we operate in. And then it's the only way to get the care that you need. So there's other things like, a patient is unable to make their own independent decisions, right? And maybe the family is not as supportive, right? And so if you have an elderly patient who needs to be transferred to a facility and no one's helping choose the appropriate nursing or rehab facility for them, some hospitals' protocol is to choose the very first referral that came in, even if this is a low-performing facility that has a CMS rating of 2 or less, where the injuries levels are high, the lack of care is evident, right? And that person will have to go to those places because it's hospital policy, and then it's tied to their performance, right? How fast can you discharge this patient because we can no longer serve them here, right? So also, this happens a lot in mental health. My students write process recordings, and sometimes I see their internal conflict. They're learning to be social workers, navigating these systems that are sometimes more harmful, right, than good. I have students that do mobile crisis for hospitals, and they go to a home, and the family clearly does not have the capacity to support the family member who has severe symptoms of mental illness, including violence. And because there's lack of appropriate placement, the burden is on the family. And there's not much that they can do. When errors are made in hospitals, right? Errors happen, even in social work, right? Sometimes you attach the wrong note to the file, and this affects the person's ability to get continued care, right? But then they won't release the records to the family because the hospital's priority is to not get sued, right? A student called me recently about a situation where the hospital is not able to diagnose their child's illness, so they called the child family advocate at the hospital because they have to put in a claim of suspected abuse. Now, this is a family of color. This is a family that is not well-resourced. The family does not have any history of abuse towards their children, but again, the patient advocate is supposed to help them navigate this, but the patient advocate has been unresponsive or not sharing the medical documents because there's a potential lawsuit for the hospital because of a previous injury during childbirth, you know? So I think that these are the kinds of challenges that advocates are faced with, and they have to make a decision that also ultimately affects their livelihood, right? This is the hospital I work for. I have a family to feed. I also want to do what's best for this patient, but you know, it could harm me. I've known social workers who have to call patients and say, don't tell anyone this is how I told you to navigate this system, you know, but you have to say this and you have to call this person, you know, and they're putting their own livelihood on the line. So I think that, you know, it's a systemic issue, and patient advocates are placed in a very difficult situation daily that causes distress and moral harm to both them and to their patients.
Thank you. Dr. Butts, what is the responsibility of hospitals in addressing public health crises that disproportionately affect marginalized communities?
So when I start my class that I teach on bioethics, I always ask 2 questions of students. So the first question I ask is, what is the definition of healthcare? And you can you know, ideate in your own head what you would answer. And then the second question, and it's very specifically how I ask this, does everyone deserve access to healthcare? All right, so of course, when you ask that question, every hand goes up. Of course, yes, absolutely, 100%. You gotta go, I'm a lawyer, so I like to parse these things out. So once the hands go up, I start to give them some examples. The second question is predicated on how you answered the first question. So how you answer the definition of healthcare is then gonna lead into how you're answering that second question. And it becomes increasingly more difficult for students because once you start to challenge them on, well, what's the definition of access? Oh, you just go wherever you want to get what you need because that's how it works. It does not. What's the definition of healthcare? Let's go back to how we defined it. Oh, but when I said healthcare, I didn't just mean an emergency where you broke your arm. That's not what you said when I asked you that question. What's the definition of everyone? Everyone. Are we sure we're talking about everyone? So then, of course, 8 weeks in the class, I ask the question again, and no hands go up. This time, they're scared or something. But it's interesting as you start to think and you parse through a seemingly simple question like that, the tentacles that go off on it are substantial. So I really appreciated your words, the words from Eric, particularly as it relates to that, because to me, your story exemplifies how we define that question. Because we would like to say, every student in my class would say, absolutely, you should get everything you need. But did you get everything you needed when you needed it? I think we could all sort of reflect on that. And the other thing I would say would be how students particularly think about this in a hospital setting. So one of the ways that I know Rami is we teach a class together around all sorts of things, or we've taught a class in the past together. And one of the things that this class has done is to look at how students reflect on hospitals and how they run and how they function. And it's really interesting because some of what we've heard from some of the other speakers in terms of the bottom line and mission and vision, it can be very challenging, especially for safety net hospitals, to be able to balance the ever-changing needs of finance coupled with the needs of patients, coupled with the needs of the hospital itself. And for students, it's really challenging to be able to sort that through but sort it through they must, because the students of today are going to be the future administrators 2, 3, 5 years from now. And so being able to have them really sort through that, it's imperative for all of us. The last thing I will say about this particular question is research that I do. So 5 years ago, almost today, on April 20th, 2020, the years it gets fuzzy, doesn't it? 2020, I, along with a few other people, started a project called the Clementine Collective. And it was born out of a class that I teach at Columbia that basically has students think about how you can take in-class problems and bring them into the real world. So we asked the question in class, and it was thinking about how to combat obesity. And a group of students came up with an idea, which was to bring fresh fruits and vegetables into corner stores and bodegas in Staten Island. And, you know, as a professor, sometimes students say something, actually a lot of times students say things, and it gives me pause. But this gave me a lot of pause. And I said, why don't we do that? I think they thought I was joking. I do not joke about things like that. So that was the last class we were in person. It was March of 2020. By April, we were in our first store, and we called the project the Clementine Collective. And it's literally a stand. Yes, exactly. Yes. Do you know why it's called Clementine Collective? Because we give out oranges. We're slick. So it's called the Clementine Collective. By the way, because you asked that question, can anybody think about why we might use clementines? Any thoughts?
Shelf life?
Why?
Shelf life, they last.
Yes, they are hardy. Also, they have their own special packaging. They have their own wrapping. They're hardy, and most importantly, they're tasty. So we used the clementines. We started with one stand in a store in Staten Island, and we gave out 350 clementines a week. And the first store that we went into, the owner said, I hope you know you're wasting your time, because no one is going to take these. They're going to accumulate fruit flies, because people in this neighborhood, that's not what they eat. The second day that we had the stand there, one of his workers didn't understand the assignment, so put out all the clementines. They were gone within 2 hours. And he said, I was mistaken. Can you please bring more next week? We said, absolutely. That was 5 years ago. And now the Clementine Collective is on its third iteration. We now are doing a study called Fair Start, where we are providing medically tailored food and clementines, always clementines, as well as yoga and exercise and literacy and all sorts of programming into communities in Staten Island. And just like Rami, I keep calling you Rami, but just like Rami was talking about with the social determinants, the ability to be able to meet people where they are, not expecting people to somehow travel 20 miles to your hospital, but having a Clementine Collective in a laundromat and having blood pressure screenings in a barber shop, so that you're saying to people, I know you can't take the 3 buses to get to us, but maybe we can come to you. And that's how, in my mind, public health hospitals can collaborate to meet people where they are, to be able to bring the services to them, but at the same time, getting people to the hospitals when they need it, so there's the trusted relationship. So that's my answer to my question.
Thank you.
Oh, thank you.
For all the panelists, how can bioethics frameworks help healthcare organizations address future reforms that prioritize financial concerns over patient care? Would you like to start?
Yeah, good start. Thank you very much, Mary Claire. In fact, actually, I think bioethics could help healthcare facilities and organizations to have a framework for their daily processes, how they can manage, if really the focus on financial outcome more than the clinical outcome. And I think that, framework should address some of the ethical principles, including justice and equity, including patient well-being, including patient autonomy, and making sure that the patient do what they want to do to a certain point, and also forcing the organization to focus on transparency and accountability. And I think having that kind of framework with those kind of ethical principles will help the organization, while there is so much pressure from the financial standpoint, to remind everybody why healthcare organization exists. It is to take care of their patient population. That's the main purpose for every healthcare organization. I believe those ethical principles will help the organization maybe refocus on their plan while they're getting the financial pressure.
Thank you.
So when we talk about ethical frameworks, kind of what do we mean? I mean, the people have been, it seems like everybody in this audience has read Tom Beauchamp's book in one of the editions. What does it? How does it really come down to make a difference? At the end of the day, it's a practical decision you're making when you're doing resource allocation. It's not a, it's not a theoretical one. You've got a number of constraints, right? Especially if you're a safety net hospital where, the patients that you're treating don't generate the resources you need, right? If you were a pure Medicaid hospital, you would be out of business very quickly. There's always some other source of money that has to be there, right? Medicaid has to have a special program for you, or the state has to have some program for you, or you have to have a large donor, or somebody has got to come up with the additional money. And you're always kind of thinking about sources and not just uses, right? It's not just we keep using that phrase resource allocation as if it weren't also a question of sources, right? Because a lot of what I think... Could you hold on to this? I'm sorry. Okay. A lot of what you're trying to do is generate resources for patient care. Not just allocate them, but generate them. And that, requires appealing to other people on ethical bases, right? That, donors or the government or the community, right? Those are groups that need to, be providing resources to make this go. And that is an ethical argument. It's not a return on investment argument. I left investors out of that list of people that you can appeal to for ethical reasons, although there might be some, right? Right. So that as you think about the resource problem, and in particular the source part, I think that ethical appeals to folks are really front and center here. And that, as a hospital management, part of what you're doing there is being an advocate for for the increase in resources. And, once you've got the resources you've got to allocate them. Right? I mean, that problem doesn't go away, but it's not strictly an allocation problem that you're trying to address. It is a sourcing problem.
I really believe in the power of centering narrative and our ability to change narratives and improve them. So there's research definitely, there's no doubt that inequities in healthcare access actually drive up costs for hospitals and for healthcare in general. Some research indicates that by 2040, we'll hit $1 trillion in medical and healthcare debt, because large in part for inequities in access to care. So if we influence those narratives with data and with the facts through bioethics framework, I think that that's one win. And then also centering the narratives of the communities and the people most impacted, right? But you have to do that through building bridges and meaningful, authentic relationships with these communities and with your patients, right? If a patient feels cared for in a hospital and feels supported, research has also shown they're less likely to sue you, right? You know, and we have all these narratives and we have all these things that we do to work around systems that clearly don't work, like telling people to lie about their family status or their incomes just so that they can get health care. You know, everyone knows this is going on, right? You know, I've known since I was in public health school when I had friends that worked at the WIC office and they had to tell their clients, you can't say that you're married. This is before, you know, everything was easily Googleable, right? Like we couldn't Google people's marriage records. Like I'm much older. So I'm just saying that, you know, we know these systems don't work, right? So how do we change that and then also have these bridges and create networks in communities? They know what they need. They know how to take care of each other, but we don't center those as strengths. And so I think that there's a real opportunity to change narratives and to center the narratives that really matter in this discussion.
I was smiling because my capstone project when I left Harvard was, why do people sue? You're definitely onto something there. When I think about bioethics and frameworks, a lot of where I trend towards is how we think about utilitarian models and looking at how we function from a public health perspective in this country. And it would be nice to think that we sort of perfectly balance the good of the many, the good of the few, but it's challenging. And when we think about safety in hospitals, and specifically the comments that we heard from our other panelists, they're right on. So it can be exquisitely difficult to be able to think about some of these balances where there aren't the resources available to be able to even think about those balances. And so I would say that as we look at the sort of tenuous balance between public health and ethics and frameworks, thinking about the resources that some places have and the resources that other places don't have, it has to be paramount. And then the comment you made about trust, to me, it kind of begins and ends there. I'll go back to what I was talking about in terms of, you know, some of the work that a lot of places do in communities. And I mean, you know, my sort of one sort of piece of advice for any hospital is being a trusted force in a community so that people, when they think of whatever your hospital's name is, they think to themselves, I trust those individuals. They care about me. I see them in the community. They value me. When I go to the hospital, I might see the same people that I saw last week at the community fair. So those are the things that I would say in terms of truly framing this from a public health perspective. The trust factor, being in neighborhoods, people feeling as though their voice has meaning, that it's collaborative. It's not just me going and giving you a clementine, but then, as has happened, somebody saying to me, where are the turnips? Oh, I didn't know that was a thing. We'll bring some turnips next week. This was one of our sites, and we did. So the people who want the bok choy and the turnips, are you listening to them? Are you bringing that to them? Are they feeling empowered to be able to talk about what they need? And I think once that's centered from a public health perspective, then the possibilities are decently limitless.
I just want to make a comment. Rich brought up really important point where healthcare facilities now, no matter what we think about it, it's a business. I mean, and everyone is pushing into that aspect. And, you know, to fix this issue from the ethical standpoint, one, I think it needs to be addressed from the public health standpoint, from the not individually from each institution. But on the other hand, some institutions, and I agree and disagree with you in a way that sometimes, you know, our safety net hospital, they think out of the box in a way that they can bring revenue, not as much as, you know, other institutions where they have a much better payer mix. So they think out of the box and they reallocate those resources somehow to focus on their mission, which is basically serving the patient population. Is it ideal? Is it optimized? I don't think so, and I think there is so much work need to be done, but I think the main thing is, from the public health standpoint and from the institution, we have to accept that at some point, that there are safety net hospitals that will not be generating as much revenues as other institutions.
Thank you very much. We'd like to open up for questions, please.
Yes, I think the most important article in medicine was written in 1927 in JAMA by Francis Peabody, who was the Director of Research at Mass General. The title was Care of the Patient. And what he said is care of the patient is caring, what is caring, patient care, it's caring for the patient. So there are two aspects to any patient care. Number one is the individual patient, which we've been discussing most of this afternoon. The person who, who's underprivileged, who doesn't have access to doctors easily, who lives in a rural area, which is where the hospital has just been closed. So that's one aspect. But the other aspect is applied to everyone, and that is what goes into patient care for all patients. Well, there is, obviously there's medical care, nursing care, but there's also public health and research. And these are all under terrible attack in this country at the moment. Number one, the CDC, which is really incredibly unique. It's made mistakes like anyone else, but there's an attempt to gut it. The person who's been proposed, there hasn't been a hearing yet, is succeeded Mandy Cohen, who was great. She resigned as soon as Trump won the election, before she was fired. And he's appointed somebody who was a Republican congressman, a doctor, but he knows nothing about public health, he knows nothing about medical care. Even worse is the proposed chief of NIH. Now, NIH is, I think, one of the most unique contributions of American medicine to world medicine, in a way that it didn't in other things. I mean, vaccines and, basic medical physiology and pathology was described in Britain, Germany, and France. But what the United States did was put everything together in the National Institutes of Health. And there have been 100 Nobel Prizes awarded to grantees of the NIH. The present applicant, or the person being appointed, is a person called Bhattacharya, a brilliant man. He's a Stanford University medical graduate. I don't think he's ever practiced medicine. He's a health economist who believes that healthcare should be more privatized and should move away from public health, etc. But what he said was, he claimed that any university, which includes medical school, which adheres to DEI, which is including this medical school, should not be funded by NIH. And they've reduced, normally any NIH grant is accompanied by, by law, 15%. Most grantors need at least 25 to 30 to 40%. Now, places with large endowments probably can handle that. But many medical schools throughout this country, including the red states, don't have large endowments. And if they don't have enough support, they will not be able to usefully work on a grant. And I'll just give you the example of glucagon peptide number 1, which is probably the leading drug in this country. It took about 25 years to develop it from the basic science aspect to its clinical use. And it's incredible, the enormous effect of this. And this was based entirely on NIH-funded research. And it's going to do a lot with individual patient care. So here we are. We already have Kennedy approved. I don't understand how the chairman of the committee, Dr. Cassidy, who's an eminent gastroenterologist, who questioned him very vigorously, voted for him. But he was only one Republican who voted against. And this person is absolutely dangerous. So here we are, not only dealing with all the problems of equity and so on, but dealing with a loss of basic science and basic healthcare on the horizon.
Thank you. Who would like to attempt to address that?
I'll say a few words. Since I'm on the, currently on the research side of the world as well as the hospital side, that is for us, the capping of indirect cost recovery at 15% is for us about a $4 million issue here at Downstate, right? That's what it would cost us from our current indirect cost recovery rate to our to this 15%. That's hard to make up, right? And it really does, I'll say, it represents a betrayal of kind of how we have looked at research in the United States, right? After the Second World War, the government of the United States did not decide to build their own facilities, right? They decided to go into partnership with the universities, right? And the universities have, in addition to the direct costs of recovery, have invested significantly in research facilities, right? Essentially thinking of the indirect cost recovery as the way the rent's paid, right? The university puts out the facility, the indirect cost recovery pays for it. And to cut that back to a point where indirect cost recovery does not cover the cost of facilities puts universities who have already built the facilities kind of in a bind, right? Now, as you say, those that have endowments and other sources to make up the difference are not nearly in the same boat as, say, Downstate, which doesn't, right? Or, in fact, it's a SUNY-wide problem, right? It's not just us. If this succeeds, it will have, it will reduce future output. I don't see any way around that. As you mentioned, the output is significant, right? It is why medical research in the United States is the world-class leader of that. So yeah, that's that is has a very significant downside if that goes through.
One of the problems I was telling this to the speaker is that the medical profession is in the public health profession has not publicly brought up and educated this country. I mean, essentially, civilized medical care as it's developed is part of civilization. The opponents of medical care are barbarians, and we're letting these barbarians get away with this, and they're going to destroy not just the individual thing, but also research. And we're not going to get a drug like glucagon or peptides easily made again. What will happen is other countries like China will invest in research. And probably certain countries in Europe as well. What I'm afraid of is that we will be forced to partner with pharmaceutical companies who do not have a vested interest in health, have a vested interest in health, just like the healthcare companies. And that's why we're in such trouble with it, and we will be in trouble with research.
And this is why these kind of discussions and forums are incredibly important. Discussion, reflection, and really reflecting on where we're going is very, very important. Thank you very much for your comments and question. Any other questions from the audience or comments? Yes, please.
One of the cudgels that is often used against single-payer systems is that, well, they have rationing and we don't, right? Of course, I think everyone in this room knows that, rationing is rife, even in our non-system. So I wondered if maybe some of the panelists could say a bit about how they see rationing playing out outside of the COVID environment. And do we need to be more forthright about the fact that, we do have quite a bit of rationing, and these are some ways it actually does play out in the American system? Thanks.
Thank you.
can say just one statement. You know what Eric mentioned earlier is it's basically summarizing the rationale, right? Like healthcare is a right for people. It's not something that you need to work really hard to get. And I think somehow, I'm not saying that's the single payer but there is some kind of defaults in some of the steps we do in our healthcare, giving that, those obstacles for patients to get their insurance, to get their coverage, to take care of their health. That's basically the rationale to address, some of the issues that we face on a daily basis. Not sure if the rest of the
Yeah, I
panel-
would echo that absolutely. I mean, I think your question's interesting to me, and that's, like I said, how I start my class, talking to students, because when we think about care and what that looks like for people, I almost wish that we could sort of start from a certain premise of, yes, we know that certain groups are getting certain things and other groups are not, and certain people in underserved areas don't have what they need. And then from there, be able to have some conversations about, well, now what do we do? And now what can this look like? And how can people advocate for themselves in this way? But if you start from a premise of that's not how it works in this country, where everybody gets everything they need and everybody has access to all the care that's available, it's really hard to then get to the conversation of no, they don't, because we're sort of stuck at that point. But then I think, if we start to think about what it looks like and how people can advocate and so forth, to me, that's that's a really interesting ethical conversation, and we need to have more of those conversations. I don't know if that answers your question, but.
I'm not saying that the single payer has no disadvantage or have their own, but my point is it needs some kind of reform that making sure that patients should not go through difficulties if they want to take care of themselves.
I'd like to thank very much our panelists.